of you. So I'm Marianne Overland, for those of you I haven't met. I'm the Associate Program Director for Primary Care and a Primary Care Director at the VA clinic in Seattle. And I'm happy to get a chance to present this. I've been, and Emily will know this because we talked about it yesterday, but I've found virtual care to be very hard this past year. It doesn't have the same energy as sharing photons with someone in the room. It's hard to have human connections, and it's really just like that joy of medicine for me, which is all about relationships, has been lacking. I went to a training in January on how to do better musculoskeletal exams over telemedicine, because I definitely felt like I wasn't doing a great job at that. Mostly relying on history. And it was a VA training, and this woman, Susan Garstang, went through shoulders, backs, hips, and knees in 1 hour. And I was like, oh my God. I was like, that needs to be a half day. And then I thought, well, I should translate this into an academic half day for everybody, because I feel like we could probably all bone up on our telemedicine skills, which went from 0 to 100 so very quickly last spring when COVID started. So that is the impetus for doing this. I have no conflicts of interest. And I do want to just name that access to telemedicine, as with access to high quality care in general, is inequitable. And many of our patients do lack access to cameras, to computers, to high speed wireless. And so I don't want to sort of ignore that fact when we go through this. Also, some of our patients don't have the physical strength or stamina to perform some of these maneuvers. But I hope this is nonetheless educational for you all. As you know, musculoskeletal complaints are some of the most common things we encounter in clinic. And as care has transitioned to telemedicine more and more, I hope we can all get better at diagnosing and treating these online. So by the end of today, you should be able to prepare your patients to maximize the utility of their visits, assess common MSK conditions, treat common MSK conditions, and then determine sort of triage. When is a face-to-face visit necessary? When should you use imaging to complement your exam, and when to refer? So for best results, I encourage you to sort of practice these maneuvers while I present them, practice them on yourself. I will go through each body part, and then we will break out into pairs to do the exams on each other. And again, sort of hope it goes without saying, please don't do anything that causes yourself pain. If you do know you have a torn meniscus, you don't have to stand there and do the Thessaly maneuver over and over again just to demonstrate it for your partner. Just tell them, I already know I have a torn meniscus. Please don't make me do this. Okay, so this is something that I had not really thought much about, honestly, before I went to this training myself. But if patients are prepared for a virtual visit, you're going to have a better visit. So if at all possible, if someone has made an appointment for you to talk about back pain, knee pain, shoulder pain, hip pain, have them get them ready, either through like an administrative person in your clinic or a nurse, if someone can check in with them ahead of time to kind of prepare them for the visit. So there are guidelines on positioning their device. There's a best location and lighting for the exam, props they might want to use. So if you think they're going to need a chair that they can sit next to, or stand next to, or sit in. If they need specific clothing for the exam, like how many times have I had an appointment with someone for knee pain and they're wearing jeans? I'm like, let me see your knees. And they're like, I can't. And so making sure people are just sort of prepared with the basics. And then prepare your monitor. If you're using 2 monitors, have the camera attached to the monitor you'll be looking at, so you're not doing this, which is me looking at you right now while my PowerPoint slides are over there, right? You want to pull up any images and resources if you plan to screen share, and then practice screen sharing ahead of time if you are not fluent in this skill. And the irony of that last point is not lost on me here. At the beginning of any visit, you want to confirm that your patient is safe. And in particular, when you're doing exam maneuvers, when the patient could potentially fall or get injured, you want to know, is there someone else at home, and what are they going to do in case of an emergency? You want to advise the patient that you might have to look away at times. I always do this when I'm on a video visit, like, hey, I might have to look at a different screen for a second to take a note or something, and I hope that doesn't seem rude to you, and just know I'm listening and I'm here with you. And then you want to make sure, obviously, that you can see the affected body part. So you might have to do some sort of testing at the beginning to say, hey, can you actually move your phone a little bit? Can you move your camera up or down? And then advise your patient that you'll be asking them to self-palpate and do self-resistant maneuvers, and go from there. Why are we not going now? Okay. Okay, so in terms of a history, it really isn't any different than in a face-to-face encounter. You do want to make sure you ask about red flags for back pain. Ask your patient to point to areas of pain. When they're doing self-palpation, make sure that you say, please tell me when something hurts, because sometimes people assume that you can tell without them actually verbalizing that. And then be explicit when you're asking your patient to perform self-resistance. And in general, you might have to demonstrate the maneuvers on yourself first. So today, our agenda, we're going to start with the shoulder. We're going to go kind of top to bottom, a little bit of didactic, and then a lot of practice. Then we'll go on to the low back and then the knee. So always good to center ourselves around anatomy. Here we have our anterior view and our posterior view of the shoulder. I will highlight sort of where we think about biceps tendonitis, where we think about rotator cuff pain, sort of glenohumeral osteoarthritis, AC joint pain, up here more for my sort of myofascial pain, up here for myofascial pain. But just thinking about what does the shoulder actually look like, and let's sort of get our brains in the right headspace. Thinking about location, anterior pain, right here, kind of, it hurts right here, pretty classic for biceps tendonitis. Superior pain, gosh, it hurts right here, AC joint arthritis. Anterolateral, we're talking about subacromial bursitis, we're talking about rotator cuff tendonitis or tears. Posterior is going to largely be muscular, could also be bursitis or tendonitis. And then diffuse pain is usually sort of that deep, achy, I can't put one finger on it pain, is going to be glenohumeral arthritis or adhesive capsulitis. So hints for the shoulder history. When you're hearing about overuse and you're hearing about overhead injury, think about subacromial impingement. And again, that's going to be diffuse over the deltoid and down the arm. It's going to be made worse by reaching up or behind back, and can be made worse during sleep if the shoulder is not well supported. Rotator cuff tear is going to be overuse or trauma. They might have weakness. They might say, I can't lift my arm above 90 degrees. The pain, again, is usually pretty diffuse, anterolateral, and reaching up or behind the back, and again, can be worse if during sleep if it isn't supported. AC joint arthritis, people usually have fairly focal pain, and it's the cross-body tasks that cause the pain. Biceps tendonitis, repetitive activities, and oftentimes people just started cleaning out their garden or, playing a new sport or something. They're going to have focal pain right over that proximal insertion site of the biceps tendon, and reaching forward is what causes pain. And then glenohumeral arthritis, pain in pretty much everything. It's deep and it hurts to lie on that side, but it does not hurt if you lie on the other side. Adhesive capsulitis usually can have severe pain and loss of range of motion, although sometimes it's not as painful unless they're trying to move it. Often there's a history of diabetes or hypothyroid. Can be worse at night and it progresses over weeks to months. And then myofascial pain is usually deep aching with sometimes a burning or stinging sensation, and it's usually in the upper or posterior trapezius muscles. And it can be caused by acute trauma or just the micro traumas of daily living or chronic strain of sedentary work or living habits, or as my husband likes to call it, tech neck, or my son calls it nerd neck. Okay, so when we're starting with the exam, we start with inspection and palpation. So this is where a tank top can come in handy, or if someone is willing to be wearing a sports bra or is topless, so that you can really see the bony landmarks. You want them to stand facing the camera at first and look for asymmetry or atrophy in the muscles. And then you ask them to turn their back on the camera and have them actively abduct, watch the scapula for symmetry of motion. You guys aren't doing this with me. I can see you. Nobody's lifting their arms up. This makes me sad. Come on. Yay, there you go. Thank you. And then palpation, say point to the area of maximum pain. Can you do it with one finger? So they say it's right there. And then you sort of have them palpate around the area and then start sort of proximal to where it hurts and then palpate around and around and around and say, tell me if you find other places that hurt. You can have them palpate along their AC or their clavicle, palpate right in the subacromial space, palpate the biceps tendon. And so rotator cuff disorders, super duper common. Just as a quick refresher, tendinopathy is just a derangement or deterioration of the tendon without a tear. Partial thickness tear seen here. The tendon function is essentially intact, it just hurts. And then a full thickness tear, you actually lose the function of that muscle in particular. So if you are doing a range of motion exam and someone has full but painful range of motion, your differential is going to be tendinopathy or partial tear. If it's limited active range of motion but full passive range of motion, you're thinking about a full thickness tear. And if it's limited active and passive range of motion and painful, you're thinking about a mechanical block of some type, so osteoarthritis or adhesive capsulitis. And then in terms of strength, if the muscle is strong but it hurts, tendinopathy or partial thickness, and if it's weak and it may or may not hurt, it's full thickness tear. So special tests, and I am terrible about names of things. People are like the Neers and Hawkins and Speeds, and I'm like, I don't know what any of that means. I can't remember, but I do remember what all these muscles do. So Neers is where you have the patient grab the wrist of the affected side and bring the arm up in front all the way over the head. Does this hurt? So grab your own arm and kind of pull it up and over. The Hawkins test is, sorry. So where'd we go? Here we go. Is where you have somebody do their own internal rotation against resistance here. So use the good arm to support the affected arm just above the elbow. Let the arm relax and then have the patient push the hand down towards the floor. Sorry, like this. So can you internally rotate? Speeds test is you have hold the affected arm out like you're holding a tray and you just try to push it down. In these pictures, one thing I've noticed, and sorry, these are obviously not me. Sorry, a neurologist will complain about this because they're crossing more than one joint, right? So technically, if you're trying to test this joint, you shouldn't cross the elbow to test it. So I recommend putting your arm a little bit higher up on the bicep to do it. And then the cross body test obviously is just reaching across. Can you pat yourself on the shoulder? Myofascial pain, it's trigger point palpation. So if you point, you can look it up on UpToDate or any place to find where the trigger points are, but usually just sort of push down along the trapezius muscles and find where it hurts. All right, does that make sense? So impingement, we're thinking about this guy and we're thinking about that guy. Speeds test, we're thinking about resisting here. Cross arm test, pat yourself on the back. Okay. In terms of treatment, for rotator cuff disorders, you really want to refer early for surgery for acute tear, for like an acute full thickness tear. At any age, or a chronic full thickness tear in somebody who's healthy and young. Somebody is like 80 years old and they have a chronic full thickness tear, surgery isn't really going to help that person. For a partial tear or tendinopathy, you can consider a subacromial bursa injection for persistent or activity limiting pain. And everyone should get PT, NSAIDs if it's medically appropriate. TENS unit can help people feel better. For osteoarthritis, again, an image-guided corticosteroid injection. So this is one that has to be done under ultrasound or fluoroscopy to get into the right space, PT or NSAIDs. And you can consider a referral for arthroplasty. For the remaining 4 surgeries not indicated, and generally we think about either injections or sometimes injections and usually always physical therapy. Acetaminophen, NSAIDs, heat and ice. So in general, you'll see the common theme here is that shoulders do really well with physical therapy and NSAIDs if someone can take NSAIDs. If those things aren't working, think about injections. And in the case of rotator cuff tears or osteoarthritis, you can think about referring for surgery. In terms of what you can do over the video and what you can't do over the video, AC joint pain, pretty easy to diagnose, biceps tendinosis, full thickness rotator cuff tear, and subacromial impingement. All of those things can be diagnosed by your video exam. You might need a in-person evaluation for a partial thickness rotator cuff tear if you're not sure about that versus sort of just general tendinosis. Myofascial pain, or if you're worried about referred C-spine pain, then obviously you want to bring them in. To help diagnose in terms of imaging, you want to get x-rays if you're thinking about arthritis or if there's any history of trauma. And then if you're thinking about rotator cuff tear, especially if you're considering a surgery referral, you want to get an MRI. Okay, so now what we're going to do is break into pairs and using the shoulder exam handout, which I hope you all have access to, take turns practicing the shoulder exam. So please practice it as if you're actually in a visit with a patient. And if you're the patient, if you want to, if you're feeling creative, you can make up some positive exam findings. So we'll take 25 minutes to do this. You'll have 10 minutes each to perform the exam on each other, and then 5 minutes for reflection and feedback. And to talk about what worked and what didn't, and if you have a different or better idea about how to do this. So I'm going to share my screen just to make sure does everyone have, am I sharing the right thing? Where are we? Is everyone seeing the virtual shoulder exam handout? Yeah. Okay. Does everybody have that in their email or otherwise accessible to them? Yes, I'm seeing some nods. Okay, great. So you will break out now. Please go through this virtual exam flow sheet here and see what works, see what doesn't work. And if you have a better idea for how to do this, we can talk about it when we get back, but it's 9:22. So assume it takes a minute or two to get ready. We'll be back here at 9:50 and then take a 10-minute break until 10 at that point. Sound good?
Awesome. I'm going to open them in
Thanks.
seconds.
Any questions while you're zooming away? We can put them in the chat, I suppose.
They're zooming away already.
Okay, good. Never mind.
So
No
we have an odd
questions.
number. We have an odd number.
Okay, so there will be a trio.
Oh, Lauren, I'm going to add her. Yeah,
Hi. Is this going okay? I'm just like micro machine talking.
This is awesome. It's really, really good.
Thanks, John, for the laugh about the micro machines guy. No one remembers that Saturday morning cartoons.
People of a certain age remember it. Yeah, the only thing I'm wondering about as I watch, because I transitioned to a small laptop because my wife kicked me off our big computer, is that when you share screen and you're demonstrating the movements,
no one can see.
It's just small.
Yeah.
And so I don't know exactly a way around it, other than I don't know if you would consider toggling between sharing screen, because then you would appear larger.
Okay.
You know what I mean?
Yeah. Hey, Caitlin.
Caitlin's enjoying the outdoors, I think.
We're in breakout rooms, but we can put you in a, maybe Javelle can put you in a breakout room and you're doing shoulder exams.
Yeah, I was dropping my son at preschool.
Of course, that's no worries. We all get it.
Yeah, so Marianne, that'd be my only suggestion. It's just a size and real estate issue on the screen.
Yeah, Okay. I don't know how much more I do any. I don't think I do any more. I might do some for the knee. I'm not really going to do back. I'm not going
Yeah.
to stand up and show my booty in the camera. Yeah.
Marianne, did you say you wanted 20
Are
minutes?
we recording this portion of this?
Oh, I hope we
discussion?
are recording this portion of it. Yeah. The real time.
We were,
reflect
but now
on
I'm going to
how
pause
do-
it.
I think ultimately this kind of thing is best just in time when you're like, oh, I need to do a shoulder exam over video today or next. Let me just pull up that list of things I should do and have it sitting in front of me so I can remember to do everything. All right, so let's take a 10-minute break. Everyone go outside if you can. It's beautiful. Breathe some air, and I'll see you back at 10. You are in earshot. We're going to start again in the interest of time to make sure we stay on track this morning. Going to talk about everybody's favorite primary care concern, non-specific low back pain. I don't know about you all, but I feel like back pain is really a hard thing to deal with because it is so common. It is almost never dangerous. And then when it is dangerous, it's a complete nightmare. And so you don't want to miss the few times when it is a huge problem. So again, like with the shoulder, we're going to sort of center ourselves around the anatomy. So here we have a cross-cut view looking at the nerve roots, the nerve root canals. Obviously, we have our disc here. We have our facets and the spinous processes. So thinking about all the different ways that a back can hurt. This bad boy here can squish out and sploosh onto this bad boy. These guys can become arthritic and push onto those guys. This guy can push backwards, worst case scenario, and hit arcata equina. And again, here we have sort of the superior lateral view, seeing all these little teeny tiny spaces that can get pinched and arthritic and bone spurry and bad as we get into our 40s and beyond. And then thinking about the sacrum and ilium in this sacroiliac joint, which is actually a pretty common source of pain for people, and I think one that often gets kind of overlooked. So we'll go thinking again about back pain by location. When people are giving you their history of their back pain, above the waist, your differential is going to be disc disease, facet arthropathy, cancer, fracture, infection, or muscular or mechanical. Below the waist, we're really thinking about this SI joint here. Or it can be, if it's in the buttock or lateral hip, something in the muscle, like a gluteus muscle sprain or strain, piriformis syndrome, trochanteric bursitis. And then leg pain greater than back pain, you think about a herniated disc or spinal stenosis. So back pain does have some common illness scripts that it's good to remember. When you think about the back pain being the main concern, if they're young and it's acute back pain, you want to think about herniated disc or SI joint pain that's worse with flexion. It can also be a muscle spasm. Obviously, that's pretty common. Older folks with subacute to chronic pain, you think about degenerative disc disease, facet pain, or spondylolisthesis, wherein the vertebrae are actually not lined up on top of each other. That's going to be worse with extension. So definitely figuring out whether it's worse with flexion or worse with extension is going to be helpful. And if someone has leg pain worse than back pain, again, if they're young, it's radiculopathy, worse with flexion. If they're old, it's usually spinal stenosis, although it can also be radiculopathy, and it's going to be worse with extension. So the difference of pain with flexion or extension is going to be an important point in your history and physical. All right. Red flags. I probably don't need to review these with you geniuses, but something to always to consider. People younger than 20 or older than 50, you want to think about cancer. People who have constant pain or pain at night. People with unexplained weight loss, or obviously if you have a history of cancer, especially the kind that metastasizes to bones. Infections, you want to think about asking if someone's had fever, chills, or constitutional symptoms, any history of chronic infection or inflammation, history or active IV drug use, constant pain or pain at night, or unexplained weight loss. You're going to see some themes here. Inflammatory arthropathies, thinking about fatigue, morning stiffness, and other joint pain, and then cauda equina, numbness or weakness, especially that characteristic saddle anesthesia, bladder retention, and bowel incontinence. Some hints for the back pain history. I promise I won't read this whole chart to you, but you do want to think about location of the back pain. Is it diffuse? Is it point? Is it midline above the back? Is it, or midline above the belt? Is it midline below the belt? Is the onset really specific, or was the onset more gradual? And does it involve leg pain or weakness, tingling, or heaviness? Exacerbating, thinking about, is extension making it worse? So lying on your stomach, or prolonged standing or walking, or is flexion making it worse? And what makes it feel better? So thinking about inspection and palpation, we get to the physical exam with our patients. We want to have our patient standing. You look for symmetry in general. Watch them walk away from you on their toes if they can, and heel walk towards you. Can they take 3 or 4 steps on their toes? Can they take 3 or 4 steps on their heels? It's a very good test for lumbar radiculopathy weakness. You want to look for pelvic drop, weakness, or trouble getting onto the heels or toes, right? So when we walk, the leg we have our weight on should be down, and the leg we have our weight off should be up, right? The hip should flex this way when we're walking. When people have certain kinds of weakness, the bad hip can actually fall when it's not the dependent hip. So you want to look for that. You want to have your patient then turn their back to the camera, and actually, if they're willing to, lift up their shirt and palpate where it hurts the most. Can they point at it with one finger? Can they even reach? I mean, some people can't reach their backs, but if they can they kind of push in one place, or is it more general? Is it over the spinous process, or is it more sort of along the facet joints, or is it in the lumbar paraspinal muscles that the pain is? Then you ask them to find their kind of iliac crest. I wouldn't say find your iliac crest. You say put your hands on your hips, and where people usually think about as their hips, that's usually the top of the iliac crest. And then where their thumbs land, if they're standing like that, is pretty close to the SI joint. When you stand like that, is that where your thumbs are? Is that where the pain is? And again, figuring out, is it midline or lateral? And then we have, our exam maneuvers. So first is range of motion. So we have our patients standing with facing the side, have them flex forward. Usually ask people to do this several times, because often it gets better over time, and they're just pretty stiff because they don't move very often. But can they flex forward to 90 degrees? And then extension, you always want to advise people to put your hands in the small of your back and then lean backwards. You want to have that support there so people don't hurt themselves. 30 degrees is normal. And then lateral flexion, again, 30 degrees from midline is normal, and then rotation 30 degrees. Oblique extension, so where you sort of have someone rotate and extend. Let's see if I can do this. So I'm standing here and I'm going to rotate and extend. That's pretty good provocative test for facet joint pain, if you're worried about that. I see there's a chat something, but I can't see it. What does the chat say? Is anything I need to know? Okay.
John Cho is just asking if you'd like people to be copying you while you're demonstrating.
Oh, yes. I mean, I want you to be adult learners and do what works for you. But it actually felt really good to do that oblique extension. So I think I might do some more of that later.
Sorry, Marianne, I'm also asking, as you're doing this with patients, because it's hard to describe in words what you mean. Are you also demonstrating for them as you're asking the patients to do?
Yeah, to be honest, I haven't with the back exam. I often do it with the shoulder exam because I'm sitting, but I think I will start doing with the back exam, because I think it is really kind of hard. I mean, the bend forward, try to touch the floor, stand back is easy, but the oblique extension is a little harder to explain. The other piece for the forward flexion that I always have to remind people is I'm not trying to figure out how tight your hamstrings are. It's okay to bend your knees, because oftentimes people think that we're asking them to like do the sit and reach that we all had to do in 5th grade as the presidential fitness testing, when in fact, I just want to know if your spine is flexible. Is your spine flexible? I know your hamstrings are not flexible. Nobody's hamstrings are flexible after this past year of sitting in front of a computer. So tell them, bend your knees as much as you need to keep the backs of your legs feeling okay. And then you can do a little bit of a hip exam as well. So hip and knee flexion, ask them to lean back in the chair and pull your knee up to your chest as far as you can, and do it on both sides. And then hip external rotation. You can say, kind of lift your right leg up off the chair and kind of swing your foot back and forth in front of your other leg. That's going to test internal and external rotation. And then strength testing. So some strength testing is better in like a anti-gravity, but are you standing up? But L2, L3, and L5, you can test pretty well in a seated position. So ask them to lift their knee off the chair and with your arms, try to push it down as hard as you can. And with your leg up in the air, try to resist it as much as you can. The quad's a little harder, but I ask people to like cross your legs over, cross your, the bad leg over the good leg, and try to like straighten your leg out by pushing down on it with your hands. Hard if you don't have flexibility. And then great toe extension with self-resistance as well. And then L3, L4, and S1, heel walking, toe walking, and a squat are a good way to test those. So can the patient rise from the chair without using their arms is a good test. So show me that you can stand up without using your arms. You want to look for proximal strength. And if they're really looking quite fit, you can try to do a single leg squat and compare sides to see if one's stronger than the other. Obviously, holding onto a chair, I think about my patients with back pain and how few of them could actually probably safely do that. But if you have a younger patient who's having acute back pain and you want to test their strength to see if they have an acute radiculopathy, ask them to do a single leg squat. Sensation, so they can test their own sensation just with light touch. Testing, touch the top of your thigh, touch the inner part of your knee, touch the inner part of your ankle, touch the outer part of your foot, and then between the first and second toes. Ask them if it feels different side to side, so they can do it at the same time on both sides to see if it feels different. And then the slump test is sort of the straight leg test for someone who can't lay down flat, where you have them extend their leg and dorsiflex their foot and then slump over. And again, this is not how tight are your hamstrings. This is, does this reproduce that shooting electric pain you have that's going below the knee? So it will feel tight for someone with tight hamstrings, and that's a muscular tightness. The question is it causing that radicular sharp shooting pain below the knee? And then range of motion and special tests, if someone can do it. The seated self-fader, remember fader is flexion, adduction, and internal rotation, which is basically pulling your knee to your chest and then pulling it across your body. And then the pain will localize. If it's groin pain, you're thinking about actual hip arthritis. If it's buttock pain, you're thinking about piriformis syndrome. And if it's lateral, it's either IT band or greater trochanter. And then the seated self-fader, across your ankle, across your knee, and kind of push down a little bit on your knee. If that pain localizes to the hip or to the groin, that's pretty specific for hip arthritis. The one thing to note is that the faber, when you do it supine, can isolate the SI joint, but when you're seated, it doesn't. So this isn't going to help us with SI joint pain. In terms of treatment, again, you will see in the other category and in the medications category, pretty common to recommend NSAIDs for people who can take them, and then physical therapy. There's very few things where physical therapy is not a good idea. So for myofascial or lumbar strain, thinking about NSAIDs, maybe short-term muscle relaxants. I'm not convinced they work very well. Some people think they do. Certainly make people sleep. But physical therapy, heat, ice, massage, acupuncture, and TENS. For set arthritis, physical therapy, heat, ice, activity modification. You can get a medial branch block or radio frequency ablation of the spinal nerve root if this pain doesn't go away or get tolerable with physical therapy and other things. For SI joint pain, actually, a corticosteroid injection is quite effective. And SI joint pain often has normal imaging, so it doesn't necessarily mean that someone has sacroiliitis just because they have SI joint pain. So don't be afraid to sort of refer someone for a corticosteroid injection if they have persistent SI joint pain. SI joint pain is super common postpartum. So important to ask your postpartum patients if they're having that pain because PT can help and an SI belt can help. And spinal stenosis, as we remember, this is like the shopping cart disease. I always think about one of our old attendings who attended forever at Harborview and at the U and would walk around with the paper chart rack. Back when we had paper charts, he would like push that around during rounds because he had such bad spinal stenosis. It made him feel better to have something to lean on. And then lumbar radiculopathy or herniated disc. If someone has severe progressive neurological deficits, you want to refer them for surgery. But 95% of the time, this actually gets better within 4 to 6 weeks. So I'd say unless someone's having neuro changes that seem to be getting worse, wait for at least a month and a half before you think about referring for neurosurgery. They may benefit from an epidural. So in terms of triaging, you think about back pain as something that you need to be hands-on about, but there are some things that you can actually diagnose over a video visit. So facet-mediated pain, again, that oblique extension maneuver can really tip you in the right direction. Discogenic pain, lumbar strain. Something that needs in-person evaluation, I'd say if someone has radiculopathy, especially if you're worried about neurologic changes like weakness or loss of function. SI joint pain might be diagnosable over video, but it's nice to be able to do a Faber test, a supine Faber test, and actually palpate what you know to be the SI joint to make sure that we're on the right track. If someone has any history of trauma and they're having back pain, or if you're thinking about facet arthritis in terms of needing injections, you want to get x-rays. And for an MRI, again, lumbar radiculopathy or herniated disc or nerve impingement that's causing neurologic changes or loss of function, obviously you need to get an MRI. But you don't need to get an MRI on every person with lumbar radiculopathy if it just hurts, because most of the time that'll go away. Okay, when to refer. This is, I think I commonly have people call me and ask me for an MRI and a referral immediately when their back's been hurting for a couple of days. And sometimes it's hard to sort of educate them about the natural history of back pain. But you want to think about pain that's not improving after 4 to 6 weeks of conservative care, constant lower extremity radiating pain past the knee, an abnormal MRI, if it's not improving, progressive neurologic symptoms, and if you're not sure about the diagnosis. And then you can refer everybody with low back pain, I think, should be getting physical therapy. You can refer to physiatry or PM&R if you are unclear about the diagnosis, for injections and for other recommendations. Rheumatology, if you're thinking this could be part of a larger inflammatory condition, you can refer for injections. I think the point here is if you're certain of the pain generator and there's an indication for injection. So if it's like chronic low back pain, refer for injection, I don't think is a good referral. But specifically SI joint pain in a 41-year-old postpartum woman who's tried PT is a very different kind of referral. And then surgery, neurosurgery, obviously spine surgery if someone's got progressive neurologic symptoms, but not for management of chronic back pain. Back pain doesn't get better with surgery. It's the neurological stuff below the waist that gets better with surgery, usually. All right, so now it's your turn. We're going to do the same thing we did before, working with a partner using the low back pain handout that was emailed to you. Please take turns practicing. Practice as if you were with a real patient. Make note of what the limitations of the modality of video physical exam is, so you can think about maybe troubleshooting some of that ahead of time. Try to focus on 10 minutes each to perform the exam and then reflections and feedback. Any questions before we break out?
Yeah, Marianne, in the chat, we have a question about why postpartum women are affected by SI joint pain.
I think it's because I don't know for sure. My guess is that the ligaments all relax in the third trimester in order to get ready for delivery, and I think it has something to do with just those ligamentous changes causing more pain in that joint. But I don't know for sure. If anyone else knows, I just sort of blame everything on that.
Yeah,
The ligaments are
hormone
loose.
yeah,
Hmm?
it gets a lot. The hormone relaxin can take a lot of
Yes.
credit.
Yes. Yes. Thank you for the more scientific explanation.
So, so let's see. It looks like we've got 25 minutes starting now, so that'll put us what at 10:55 coming back in.
Hmm. Perfect. Great. And then we'll take a 5-minute break after that. Thank you.
Thanks, everybody.
Joelle, did you restart the recording? I forgot to remind.
All right, John, just for you, we're including just a basic hinge joint.
Thank you,
Well,
Marianne.
should only go in 2 directions. It's a little bit easier to do. The virtual knee exam. So this is again something that you think, oh gosh, I need to see this person in person to be able to do a good exam. And there are quite a few things we can do over video. So just again to sort of center ourselves on the anatomy. Here we have anterior, superior, and posterior views of the knees. And I'm not going to review first year of medical school with you today. But good to sort of think about your approach anatomically. Knee pain by location. So thinking about lateral, anterior, and medial knee pain. Lateral knee pain is typically going to be IT band pain. So just right along here, usually happening in runners or people who are physically active. LCL sprains, the lateral collateral ligament, lateral meniscus tears, and then osteoarthritis if there's tenderness right along the joint line. Anterior pain, we're thinking about quadriceps tendonitis, patellofemoral pain, which is more of sort of diffusely anterior, patellar tendonitis, which is going to be a little more focal, and then infrapatellar bursitis. And then medial, we have MCL sprain, the medial collateral ligament, OA, again, right along the joint line there, medial meniscus tear, and then pes anserine bursitis, which is going to be a little medial inferior to the knee. Again, a big chart that I'll try not to bore you with, but there are certain locations and symptoms that are going to clue you into where you should be thinking the knee might be. People will describe osteoarthritis as pain deep inside the knee. It has flares, and then it sort of has periods of a little more remission. Effusions can come and go, and it's worse with weight bearing and gets better with rest. Patellofemoral pain syndrome, I think, is very common. Common in people who've been runners, common in people who've been in the military and done a lot of marching with a lot of weight on their backs. It's pain in the anterior knee. There's crepitus with movement. It's worse, especially going downstairs. It's classic. People say, I feel fine walking flat. I feel fine walking up, and I go downstairs or downhill and it kills me. And also it gets painful with prolonged sitting. Repetitive bending and straightening is making it worse. If you have pain over a tendon, and it's usually associated with overuse, that's going to be quadriceps or patellar tendonitis. Ligamentous tear usually involve a trauma, and often you'll hear a story of someone was, weekend warrior, went back to playing soccer after having not played for a year and planted, twisted, and went pop. They will have immediate swelling after the injury, which is usually can be hemarthrosis, and the knee will generally be described as feeling unstable. A meniscal tear, there's traumatic meniscal tears, and then there are degenerative meniscal tears. Traumatic meniscal tears are usually associated with a twisting injury. Someone was, playing basketball or playing volleyball and jumped and landed and turned and felt a pop. The swelling is usually delayed by a day. So unlike a ligament tear where you have immediate big fat painful knee. A meniscal tear really comes back to bite you the next day. So a lot of people with a meniscal tear are like, yeah, I felt weird. And then I actually like went and skied another 3 runs. And then the next day I couldn't walk. So people have a perception of locking or catching as that meniscus is torn. It causes a catching spot for the joint. And the pain might be sort of along the joint line, but it also might be inside the knee. And weight bearing and twisting is painful. And then IT band is going to be lateral over the distal IT band as it's inserting into the tibial plateau. It's tight and tender to palpation. You can usually feel it. And repetitive bending and straightening makes it worse. And then pes answering bursitis. So the pes, it hurts to touch the pes answering bursa. This often goes along with knee OA or patellofemoral pain. So we start our exam with our patient standing and facing us, and you just want to observe alignment. Does someone have a varus or valgus knee deformity? Valgus, the knees are locked together, and varus, they're really far apart. This is how I always remember which one's which. You probably don't need help with that. And then you want your patient to walk away from you and walk towards you, check their symmetry, see if they have that hip drop where, again, your pelvis should tilt as you're walking, and if your hip pelvis is tilting in the opposite direction, that's a sign of intrinsically weak pelvic muscles. Foot pronation or supination, is someone flat-footed? Are they rolling their ankles? And then you're going to have them seated at the and facing to the side for sort of range of motion extension or hyperextension. So you just want to have them sitting parallel to you and see how far up does your knee flex. Sorry, extend. When you're thinking about palpation, you want to just have them if you can, have both knees in view so you can see what the good knee looks like. Look for swelling, atrophy, or scars. Have them, again, try to point to the area of maximal tenderness with one finger. And then using patella as home base, have them do the quad tendon above the knee, the patellar tendon below the knee, along towards the pes answering bursa, and along the joint line for LCL, MCL. And then you can think about hip and knee flexion, hip internal and external rotation like we did with the back exam. Stability testing, you want them to be standing. And so for checking for stability for the medial and lateral collateral ligaments, if I can do this probably. Let me get my camera here. So I'm up on one leg, my weight is on that leg, and I'm going to put pressure on the medial and lateral joints to see if there's an instability. And then the Thessaly test is what I think of as my twist and shout test. I'm going to stand on one leg, holding onto a chair, and I'm going to actually twist my knee joint and try to keep the hips sort of stable so that the hips aren't the things that's twisting. I'm not twisting my hips, I'm twisting around my knee. If you can tell that, this is me twisting my hips, and this is me twisting my knee. There's way more information than any of you ever needed to know about me. But a Thessaly test will be positive because someone will go, oh my God, that's it. That's the thing that hurts. And I find this to be a pretty reliable test for meniscus pathology. Palpation and special tests. So Noble's test is where you put pressure over the distal IT band above the lateral joint line, and then you like flex and extend the knee and see if you get like a pain or popping that actually is hurting right now, which is surprising to me. And then your patellar mobility, you're going to have your knee up and relaxed, so supported, and see how mobile that patella is. And then patellar compression, you want to have the leg extended with your foot flexed and tighten the quads. And sometimes you can even like kind of push down on the knee, but see if doing that in an active way causes pain, causes crepitus. You can often feel, the patella kind of grinding a little bit. Does that make sense? Sort of, kind of. You guys will get a chance to practice here in a minute. In terms of treatment, for osteoarthritis, there's always knee replacements. We can try corticosteroid injections or Synvisc, APAP, NSAIDs, glucosamine and chondroitin. work in about half the people who take it. They have benefit. I always tell people, give it a few months, and if you haven't noticed any difference, don't keep going because you're a non-responder. And then unloader, offloader braces. Patellofemoral pain is really physical therapy, physical therapy, physical therapy. You need to tighten, you need to strengthen the quads, you need to relax the hamstrings, you need to make sure that that things aren't being pulled out of alignment. Meniscal tears. Sometimes meniscectomy is helpful, less helpful for degenerative tears, more helpful for more acute things, but oftentimes it's physical therapy, physical therapy, physical therapy. And then there's some data for platelet-rich plasma, although I can't get that for anyone at the VA, so it's not something I'm super familiar with. Ligament tears actually usually don't need surgery. In some circumstances, you do. And again, PT and bracing. Pes answering bursitis does well with topical NSAIDs. And then IT band syndrome does well with NSAIDs, PT, heat and ice. So things that you can diagnose over a video visit. Usually pes answering bursitis, point at it and it hurts. That's fairly straightforward. Patellofemoral pain, as long as someone can do the patellar compression test, if that is painful and you have this history of hurts to go downstairs, hurts to go downhill, hurts to stand up from a seated position. That's pretty classic. IT band syndrome should be pretty diagnosable, and then some meniscal tears, again, if that Thessaly test is positive. If you're worried about a ligament injury, I think checking for instability is really hard to do on yourself. And so that would be something that I would bring someone in for, and then some meniscal tears if you're not sure. In terms of what needs imaging, osteoarthritis, I think we should get imaging of that. And anytime you're worried about any trauma, and then for MRI, anytime you're thinking you might need surgery for ligament and meniscal tears. All right, so now it's your turn. We have 27 minutes. This should work great. Let's see if we can do this in 20 minutes since it's an easier exam. So 10 minutes each, and then come back and we'll have a few minutes to reflect on how this went.
Marianne, I might add also, I think if the joint is hot, that I probably would want them to come in to,
Right. I should add that. Yeah, anytime we're worried about a septic joint in general.
or if there's like a
Or-
possibility of aspirating and looking for like crystals.
Yeah, that's good.
I think I got kicked out of Zoom for a second and now I got let back in, but I'm
Yep, just give me.
one breakout.
A couple folks not yet joined. I'm not sure why.
Yeah. I'm guessing those are the people getting coffee.
Yeah, maybe.
All right, I added a comment. Hey, Annie.
I'm in a breakout room of one.
Oh,
Yeah, I think Andy may be in your room. Yeah, Andy's in your, your room.
Oh,
there's
sorry. Throw me back. Can I go back again? Join breakout room. Oh,
Yeah, you should be able to get back in there. Yeah, Andy must be getting coffee.
John, I added a line about having someone come in if they have a hot risk fusion.
I think so. It's not that often, right? But we wouldn't want to miss that one.
Yeah, I'm like so tangled right now. I don't even know what's going on. After the last little didactic session, John very aptly pointed out to me that anyone who has an effusion, especially if it's hot or red, should be seen in person. So I just want to make that very clear. If that knee looks hot and red and puffy, then have them come in right away because you want to tap that. Tapping knees is one of the great joys in my life. I hope it is also one of the great joys in your life. I find it to be one of the more satisfying things that we do in primary care. Just getting a big old effusion out of a knee joint makes people feel so much better. All right. So I'd love to reflect for a bit, for a few minutes on what was easy, what was hard. Does anyone have any thoughts on when you might have an opportunity to use these skills? What are the barriers to using these skills? And did you discover any barriers and then come up with ways around them? So I'd love to hear what people think about that. I'm going to stop the screen share just so we can all look at each other. I know it's hard to ask a group this big for volunteers, but if anyone has any thoughts about how this went and when you think you might use it, what was hard, what was easy? Lauren, that's a great question. I think it's great if there is a family member nearby. I think one thing to help with like stability, to make sure someone's going to be safe, and also to help with the strength exam, I think that's a great idea.
I thought this went fantastic, and I think that I'll probably use it quite a bit. And I feel like recently I've been struggling through assessing joints, telehealth, and kind of going blind and trying to just flag off what are the red flags in my mind, and just refer people to PT. So at least I'll have a little better way to go about it now.
Thanks, JP. Ultimately, the final common pathway for many of these things is PT, so you're not wrong. I think for me, the big takeaway is, can we figure out what's an emergency and what's not, over telehealth? And I hope so. And can we offer people some reassurance? I think oftentimes people want an exam anyway, right? They want to be touched by their doctor. And so it's hard to kind of convince people that they don't always need to be touched by their doctor, but this can be kind of an in-between space where we're kind of touching them, but not really.
I found trying to get the right camera angles to be really hard, where you can see things. And I think especially for people who have more like fixed webcams, that would be really hard. That might also be helpful for the family member to be the one like holding the camera while someone is doing things, where they could actually direct a camera a little bit.
That's a really good point, Annie.
Yeah. I had the most fun with it when I started like pretending I was an aerobics instructor with it, like, and leg up and leg out, like bringing some of that energy to it was, I don't know. I'm looking forward to doing that with patients now.
Yeah, I appreciate you bringing your aerobics instructor energy to the physical exam. I'm imagining you like Jane Fonda now, because my mom totally worked out to Jane Fonda video tapes when I was little. And if any of you didn't know that Jane Fonda had a whole videotape, had like a video empire of exercise, it was amazing. What was I going to say? Oh yeah, and I think the other thing is camera phones, right? Camera phones can be a blessing and a curse, because they are really easy to move around, but also I find with my older patients, like I was kind of joking, I'll be like, show me your foot that's swollen. And I'm like seeing their ceiling fan, right? And I'm like, no, you have to turn the camera around. And then they like turn the phone around, and I'm still, and I'm like, oh my God. So yeah, if they have a family member around, it makes it a lot easier. And because if a cell phone's on a shelf or something, you just might not be able to find the right angle. So it's an imperfect science for sure.
Also, you don't know really which way the camera's flipping the person, so they should tell you which is their right and left, because you might be making assumptions and it's wrong.
That is actually a really good point. If they have printing on their shirt, you can sometimes tell, but otherwise you don't always know what's right and left. You can't assume that you're seeing like the patient. You can't assume that it's not the patient's mirror image that you're seeing. Great point, Sarah. Thank you.
I think similarly to having troubles with sort of camera instructions, I felt like I was saying just a lot of words, and I imagine that would get easier and more streamlined as time went on. But even so, I think it's a lot of really complex instructions to our patient that we're examining. And for some patients, I'm sure that would be just fine. But for many patients, especially older patients, I think that would be quite hard.
Mm-hmm. Yeah, that's a great point, Hannah. So maybe just trying to think about how to modify this so that we're ruling out the scary stuff, triaging, and then bringing people in if we need to, and that's totally fine. The other thing I was asking John about, because I don't have any experience with this myself, is working with video interpreters. He said it was pretty smooth and might be helpful, but sounds like the UW has a fairly good video interpreter access. So that's good to know. But that might be another barrier potentially. Oh, right, John, share screen is great. And I often do share screen when I'm showing people pictures of musculoskeletal things or showing people dermatomes. And we talked about this, Hillary brought up the point of like doing a kind of a sensitive exam on yourself while also asking the patient to do kind of a sensitive exam, and her touch your inner thighs and tell me if it feels normal. Might be a weird thing to ask someone to do on camera, and especially if you're demonstrating on yourself. So sharing a screen to say, hey, I'm going to show a picture here. If you can like touch yourself in that area and tell me if it feels the same on both sides and if it feels normal, that can be a nice thing to do. Great. I want to respect everyone's time and make sure that we get you out in time for your activity. But let me just say thank you. You are beautiful people. I appreciate you so much coming in here and giving it your all. I hope this was educational and you feel a little more comfortable thinking about ways that you can use telemedicine to expand your practice and expand access to people. Keeping those people who live far away from having to come in for an exam if they don't need one. So thank you all. Have a great afternoon. Happy April Fool's Day. I did not prank anyone today. Should be thankful for that. Happy Easter this weekend if you celebrate, and have a great day.